Okay, it looks like everybody is in. Still climbing a little bit, but we'll go ahead and we will get started. So hello and welcome. My name is Ryan Tappy and I work with the ALS Association. Thank you for joining us for another installment of our Living with ALS webinar series. The title of today's webinar is Food, Fluid, and Formula: Navigating Nutrition in All Its Forms with ALS. There are a few things we want you to know before we begin. First off, please know that you are muted and not on camera, so you can relax and enjoy the presentation. There will be time at the end of this webinar to answer questions. You should see a chat box feature on your screen, as well as a Q&A feature. You can use either of these options to submit questions you may have. All messages submitted will only be viewable by the host and panelists. We will review and answer these questions with our speaker at the end of the webinar. We do have a very short survey we are asking that everyone complete. The survey will appear in your browser once the webinar ends. This survey helps us to know your thoughts on this presentation and topics you would like us to consider in the future. Lastly, this webinar is being recorded and will be available on our website in the Care Services webinar page within about a week. Adequate nutrition is a vital aspect of living well with a diagnosis of ALS, and a topic we try to cover almost every year in these webinars. Joining us today to discuss this topic is registered dietitian Jackie Klunk. Jackie is an outpatient dietitian on the UPMC Presbyterian Outpatient Nutrition Services team. She received her Master of Science in Nutrition and Dietetics from the University of Pittsburgh. Jackie has experience working in both inpatient and outpatient clinical nutrition settings. She currently works with a wide range of patient populations and diagnoses through the General Nutrition Counseling Office, the UPMC Adult Spina Bifida Clinic, and the UPMC ALS Center in Pittsburgh. She is dedicated to delivering evidence-based care tailored to each individual's needs with an approach rooted in compassion. Thank you so much for joining us today, Jackie. I'm going to hand it over to you to present, and I will return for the question and answer at the end.
Right. Thank you so much, Ryan, and thank you all for being here today to listen. Again, my name's Jackie. I am the dietitian over at UPMC Presbyterian Shady Sides ALS Center of Excellence Clinic. And so let's jump right in, and I'll start off just by noting I don't have any disclosures other than my employment for today. So for today's presentation, we're going to spend some time going through what the role of a registered dietitian is in an ALS clinic and how to best utilize that resource. Identified what the current guidelines are for nutrition for ALS and how to decipher different diet and supplement claims. Talk about some ways to actually practically apply some of those nutrition guidelines. And then lastly, spend a little bit of time talking about feeding tubes to hopefully help increase comfort around talking about this topic, both with your family and with medical team members. So jumping in first with the role of a dietitian in an ALS clinic. A registered dietitian is a credentialed nutrition expert. It's required that a registered dietitian go through an accredited bachelor's and master's program, do 1,000 hours of supervised practice, and pass a national registration exam. So your dietitian is really your nutrition expert in clinic. So in an ALS clinic, generally speaking, that dietitian will be able to do a thorough nutrition assessment, provide then education and counseling on evidence-based nutrition information. And that can help a variety of different areas of nutrition that a person with the diagnosis of ALS may encounter, such as making sure you're getting enough nutrition and hydration, ways to maintain weight, GI symptoms, supplements, overcoming barriers to make that happen, and managing tube feedings. It's also very important that we communicate with other team members on our multidisciplinary care team. So how to best utilize the dietitian in your clinic, I think will vary. One is that, we do know that some clinics do not have a registered dietitian on staff. Some clinics may offer the ability for your dietitian to see you in clinic and one-on-one through virtual or in-person visits between clinic. I'm lucky enough to be able to see some patients one-on-one in between, but there are some clinics that will only be able to offer the dietitian as a resource at those clinic visits. So you want to make good use of the time with the dietitian. So I always say that some important things are to be open and honest. There's never any judgment in the room. but the more information that we know, the better we're able to provide accurate answers that are the most helpful to what your goals and your preferences are. Ask that question. There is no question that isn't worth asking. And it sometimes can be helpful if you're leading into clinic to kind of jot down what questions you might have, not just for your dietitian, but other providers, so that it doesn't get lost in kind of the flow of the day. Keep your dietitian updated, especially if you are able to have some direct contact with your dietitian in between clinics. I would much rather, and I always encourage my patients to reach out to me as soon as they notice a change, like weight loss or a change in their food intake, rather than wait the next few months until I get to see them in clinic, where these things could have progressed over time. So when you have the chance to keep someone updated, your dietitian or otherwise, keep them updated. I also encourage revisiting any handouts that your dietitian has given a few times a year. Oftentimes I'll suggest after clinic. And that's because sometimes nutrition ideas that were listed on a handout may not have been helpful for you initially, but eventually become helpful or become something that you're interested in trying. And then know who to contact, and if you're not sure, ask who your contact should be. Though I always say, if you manage to find one of us on staff, we can all find each other, so we can always get you in the right direction. Of course, if you don't have a dietitian as a resource at clinic, you can try to see a dietitian locally. Usually that's billed through insurance, so it's important to kind of determine if you have coverage for the visit when scheduling. But I did put a couple links here that hopefully are helpful for future resources. To the Academy of Nutrition and Dietetics, where you can find local dietitians, but also some ALS nutrition resources that are reliable. We have the ALS Nutrition Group, which is a resource website that came out of the Northeast ALS Resource Consortium. The ALS Association itself shares resource guides and has a nutrition-based one, and youralsguide.com also has some good information about nutrition. So jumping into diet and supplement claims. Right now, there are no specific diets with conclusive evidence behind their use in helping ALS. And it's also important to note that nutrient absorption itself, vitamin mineral needs don't change in ALS from baseline. Instead, the goal with diet in ALS becomes adequate nutrition, just as the body still needs all of its different vitamins, minerals, carbs, protein, fat to function, and weight stabilization, trying to keep that weight as steady as possible and avoid weight losses. That usually means increasing calorie and protein intake for most people, and we'll dive into that a little bit more in a minute. But what that also means is that there's not specific foods that you have to include or have to exclude because of the diagnosis itself. Now, I'll still encourage patients, we still want to have a variety of foods, we still want to get all of our food groups, but there's nothing that is specific to the diet that changes in terms of excluding and including foods because of ALS itself based on current evidence. The reason we spend so much time focusing on that weight loss piece is that our research shows that weight loss and continued weight loss in ALS can decrease quality of life and length of survival. So that's an outcome that we really try to work on through nutrition. So some of the common questions that I'll get asked about nutrition and diets with ALS would be, why do I have to eat more? Why are you suggesting I eat more if I'm less active than usual? Or often, why am I having weight loss if I don't have any trouble swallowing? Well, we do see weight loss that is not always associated with dysphagia or trouble swallowing. A recent study showed maybe about 35% of the case of weight loss that was investigated in the study was for people who did not have dysphagia symptoms. The other piece of things is that even if you're less active than usual, many people with ALS are what we call hypermetabolic. It basically means that the body is using more energy than it did before diagnosis. We're not entirely sure exactly why that happens, and current estimates suggest that about 50% of people diagnosed with ALS are hypermetabolic. But some of the factors that could be going on here are increased energy for everyday tasks, basically meaning that the body is putting in more effort to do our everyday, tasks of living. Muscle fasciculations, those are the little twitches in our muscle fibers that some people with ALS do get. And those twitches are the muscles moving, so they are using energy. There's also increased work of breathing, so meaning that the body is putting in more effort and energy to breathe. When someone does utilize breathing support, often called non-invasive ventilation, that does ease off some of that work of breathing a little bit, but still the body is just putting in more effort to have breathing. And there are some questions as to there might just potentially be changes in the body's metabolism itself with ALS. We just don't have a clear understanding of exactly what and why that might be at this time. I also often get asked, will having a high protein diet bring back muscle? And unfortunately, I mean, for the most part, unfortunately, no. And that is because the majority of the muscle loss that is seen with ALS is due to a loss of connection between the nerve and the muscle. And when that muscle no longer shares a connection with a nerve, that muscle does begin to atrophy, meaning it decreases in size or wastes. So adding more protein when there's no connection between the muscle and the nerve will not bring back muscle. But we do know that people who don't take in enough protein in their diet will lose muscle mass because of that undereating. So encouraging good protein intake is more to help ensure that undernutrition is not an additional cause of muscle mass loss. And then lastly, because we do talk a lot about increasing calories and protein, I thought sugar was bad for you. And I think there's a couple ways that we can look at that. One is that healthy can change based on what your medical needs and medical situation is. We see there's real risks with having weight loss occur with ALS. And so the positive outcome that we're looking for is keeping weight stable. And so using some higher sugar, traditionally less healthy foods, along with our healthy foods, I still don't recommend cutting those out, but adding some of those things can help be a tool in your toolkit to help avoid weight loss. But again, it's still important to include those along with the nutrient-dense foods that we would normally eat. Of course, there's additional considerations you'd have to talk with your ALS team about if you have diabetes prior to diagnosis. We've also seen some recent research published in 2024 that showed that a high glycemic index diet was associated with slower functional decline and longer survival in ALS. Now, glycemic index is kind of a way that we can categorize foods based on how quickly they make our blood sugar rise after a meal. So foods that are higher in a glycemic index tend to make our blood sugar rise more quickly after we eat them. So things that are full of sugar or refined carbohydrates do tend to be higher in their glycemic index. But while there's much more research that still needs to occur in this area, that is a study that showed that, these foods may not be harmful for an individual with ALS, but actually may have some positive benefits. So at the end of the day, while I will still say no one's going to feel good if they just eat sugary things 24/7, we still want you to have all your food groups. Having those foods that are traditionally viewed as less healthy can actually be a positive for some people in ALS to reach their individual nutrition goals. And it all has to be personalized too. I have some patients who within their family choose that they don't want to necessarily have certain foods around. Maybe they have young children and they, don't want to be eating certain foods where those young children are present, maybe can't enjoy them. There's other dietary needs in the household. So we can absolutely increase calories from, a more traditionally healthy food lens. However, I always say don't knock the ice cream, don't knock the sugar. It is okay. From a standpoint of supplements in ALS, similar to diet, there are currently no supplements with conclusive evidence for their use in ALS. Now, of course, if someone in their diagnostic workup process, if an existing vitamin or mineral deficiency is found, that should be corrected. That should be based on lab work, dosed and monitored by a doctor. And generally, this is not related to ALS itself. It just might be a deficiency that was kind of uncovered in the diagnostic process. And people who struggle to eat a variety of food groups, maybe due to appetite or dysphagia, may benefit from a standard multivitamin with minerals, but there are not specific supplements we recommend across the board to ALS patients. But then, I'll often get that question, is it still worth a try? And, with a disease without a current cure, it's understandable to want to try different things if there's a chance that it may be beneficial. And that's where I encourage really having those open, honest discussions with your ALS team. Some of the things that I'll think about when a patient comes to me and wants to discuss that is, Okay, if we don't have evidence that this is beneficial, we have potential benefits, then it's important that we weigh the real and existing risks against them. So that could be things like medication interactions. It could be medical history that might contraindicate a supplement, the safety of the supplement. Unfortunately, dietary supplements aren't regulated by any agency. So if the supplement isn't purchased from a reliable company, we may see situations where there's contaminants, there is too little or too much of the ingredient that they're claiming is in the supplement, or it was manufactured with unsafe practices. So, that's something to consider, reliability of the brand, but also thinking safety in terms of side effects. How these supplements fit into your budget. I would never want someone to purchase so many supplements that they were no longer able to afford basics such as daily food. Appetite, having a really extensive pill, powder, supplement regimen can sometimes really diminish someone's appetite. And then also we want to make sure that we're not avoiding what we know to be effective, and make sure that we're trying the things that we know to be effective. From a medical standpoint, any medications your ALS physician might recommend. From a nutrition standpoint, making sure that we are still trying to increase calories and stabilize weight, and making sure that we're not avoiding the things that we know to be effective. So at the end of the day, I think it's an important discussion to have, and the more open and honest we can be with kind of running through, here are the risks, and where can we go from there in a way that honors your autonomy and the things you want to try, while still not putting you at any increased risk of lack of safety. There are some really great resources to find reliable information on supplements in ALS, namely ALS Untangled. The website is listed there. This is a group where ALS professionals scientifically review alternative and off-label treatments for ALS to assist people with ALS and their caregivers on having those informed discussions. And oftentimes these ALS Untangled reviews get updates and webinars offered by the Northeast ALS Consortium, or NEALS. The last one was done in June 2024. I've linked it below. It was given by Dr. Bedlack out of Duke, and is a free webinar that is available if you'd like to have kind of a webinar that reviews that current update of evidence. All right, so jumping into how do we then practically apply these nutrition guidelines to food? What I'm going to start out and say is with this section is there's a lot of wordy sections. And it's not so much that I'm going to go through every word, word for word on the slides, but more so they can serve as a reference for later if helpful. So if you'd want to grab a screenshot or come back to the recording and grab a screenshot, can be hopefully helpful as a resource, but always, check with your specific medical team or dietitian if and as appropriate. So some of the main kind of ideas that we're thinking about with practically putting the nutrition guidelines into place, because it's not a specific diet, it's the goal to keep your weight stable, is how do we achieve that around any barriers a person might face, be that time, be that things like loss of appetite, fatigue, feeling full quickly. So some of the strategies we can use for those things, like loss of appetite, fatigue, feeling full quickly, are smaller, more frequent meals. A good rule of thumb can be try to eat something every 2 or 3 hours during the day. For some people, that's taking their 3 big meals a day and splitting them in half, so they eat them in 2 different sittings. Some people do 3 smaller meals and add 2 or 3 snacks or nutrition shakes between. Can adjust the texture of foods, not just for trouble swallowing, but for energy conservation, where softer foods are easier and take less energy to chew and swallow as the day goes on if someone becomes more tired as the day goes on. Avoiding diet and light foods that don't have a ton of calories. Avoiding filling up on liquids before eating. This obviously does not mean the liquid sips you might take between bites of food to help with dry mouth or ease safety of swallowing, but more so it means, don't down a big glass of water right before a meal and then you're too full to have that food. Keep favorite foods around, as well as convenient or pre-made kind of grab and go meals and snacks. And in this situation, home delivered meals can be helpful. They can be cost prohibitive. There are some insurance plans that do offer some home delivered meal coverage. So usually there I'll encourage an individual to call their insurance company and ask if they have any home delivered meal benefits. There also are ones that are offered out of pocket. They can offer different medically tailored meals, including a couple that offer pureed meals if that is needed. So that can be a resource that a lot of people will find helpful, even if they're not using them all the time, just to keep in the freezer is something that can be quickly put into a microwave if needed. And then sometimes, we'll talk about setting external reminders to eat, such as a schedule, kind of like we take medications on a schedule, trying to eat at certain times during the day, or setting alarms on a watch or phone. And I always say, we have to approach that kind of advice with some compassion. I would never be telling someone to force feed themselves all day long or feel like they're just bound to the clock by eating. But when we don't have those internal cues for appetite telling our body to eat, sometimes we have to create some external cues to make sure that we're getting in some nutrition. And I always say it's to try to put it with no pressure. And what I mean by that, sometimes I'll also phrase it as don't feel like you need to be part of the clean plate club. And what I mean by that is not that I wouldn't want you to finish your meal or snack. If you can, that's awesome. But the key point is that you shouldn't feel pressure to, because sometimes people will say, I'm not going to bother to get that meal or that snack because I know I'm not going to finish it and I don't want to waste it, so I'm just not going to get it. I would rather someone take one bite of it and get that one bite in than not try at all. So that's what I mean by try to get something every 2 or 3 hours, eating on that schedule. But it's okay if you only get a bite or two. That's better than not getting that bite or two. So this is a chart, hopefully, that can just be a helpful reference that talks about maximizing nutrition per bite or sip. The basic idea here is that if someone's appetite is lower, their fatigue is higher, generally when we say get more calories, it doesn't always mean that you can eat more food. So we have to maximize what you get for every bite and sip that you take. So we can use fat, we can add sugar, we can also add protein, which does add extra calories. And this is a chart that, again, you can screenshot or come back to, if it's helpful to kind of review some of those different ways that we can add those into our foods. And again, just a reference as a resource of what we might mean as a high calorie snack idea. So just some examples, you could do a whole fat Greek yogurt with some banana and honey. You could do something like half a grilled cheese and condensed tomato soup that was made with half and half instead of with water or milk. So again, something you can screenshot and reference at a later time. But they don't have to be huge in volume. They can still be soft. They can still be tasty. And another way we can increase our calories and protein are through oral nutrition supplements. We often call this ONS. So if you hear your dietitian ask about ONS, that's usually what we mean. And so these are those commercially made nutrition shakes that are often high in calories and protein. And they can be a convenient way to get calories and protein. A 2013 study looked at a population of patients with ALS who were using high calorie ONS, and 60% of those patients who were using it reported weight stabilization or regain. And there's lots of different options that are out there on the market for different dietary needs. There's plant-based versions, there's dairy-based versions, there's even different forms. So not just our milkshakes, but there's juice-based forms, gelatin-based forms, ice cream-based forms. I've seen condiment-based forms. So there's lots of different ways we can get it. But the key that I'll recommend when we're considering what nutrition needs are for ALS is that we don't just want the protein, we want the calories too. And that's because a lot of these supplements that are out there on the market, are often made for people who are having a goal to lose weight and they want extra protein, but they don't want extra calories. And so while those can be used if needed and they can be used in strategic ways, if someone's only going to pick one product, I'm going to want them to get something that gives them the calories as well as the protein. So again, we're thinking about maximizing nutrition per bite or sip. So a good rule of thumb is to have at least 250 calories and 15 grams of protein in the shake, though as always, talk with your medical team for specific recommendations. But that can be a good kind of baseline to make sure you're not getting a product that's too low in calories. Can absolutely, anything higher than that, we can absolutely go for. There's shakes out there that are upwards of 500 calories for a little 8-ounce shake. So there's different ways we can do it, but when I say a high calorie and protein shake, what I usually mean is that it's got at least 250 calories and at least 15 grams of protein. Though sometimes the flavor can get a little bit old, especially if it's something you're drinking regularly every day. So we can definitely adjust flavors. If it's too sweet, you can dilute it with milk or a plant-based milk. You can add flavoring agents if the flavor is just tiring or you want to switch it up. adding extracts like vanilla or peppermint extract, adding spices like cinnamon or pumpkin pie spice, adding syrups, whether that's truly like chocolate or strawberry syrup, or things like caramel, honey, maple syrup, coffee syrups can be a good way to get different flavors in there. Decaf instant coffee can be a good way to get a different flavor in there. You can make a mocha with a chocolate shake. And we can also use these shakes in recipes to change up the flavor profile. So using them in smoothies, but also using them in oatmeals. We can bake with them. And a lot of the companies that make these shakes do offer nutrition recipes on their websites too. And we can also use protein powders. Though they're lower in calories, we can absolutely use protein powders in recipes as well. So kind of moving on to another barrier that may be something that an individual will have an ALS that can affect their food intake. We've got dysphagia. Now, of course, here I have to give that recommendation over to talking with your speech language pathologist who's looking at swallowing at your clinic to give you recommendations in terms of what is the safest for you to swallow. But in terms of transitioning that to food, some of the generalized things that will suggest to make foods a little bit easier to chew and swallow and control in the mouth would be to keep it soft, moist, and cohesive. I would say there's kind of the difference between a meatloaf with gravy that's nice and soft versus like dry taco meat that's just ground up and really crumbly. Both can be tasty, but texture-wise, that meatloaf with gravy is going to be much easier to eat. So sauces, gravies, and condiments used liberally can both make things easier to eat, but also add some extra calories. We can soften dry, crumbly foods like cookies or toast by dipping them in milk, juice, coffee, whatever makes sense and tastes good to you. Can peel fruits and vegetables, remove tough seeds, cook them to fork tender. That can be a helpful tool. Use more moist methods of cooking meat like slow cookers. Cut meat into small pieces, like about the tip of the pinky finger can be a good rule of thumb. And while not everyone will need to follow this, these are some general things that can be places to start as ways to adjust the textures of foods to make them a little bit easier. And these are some examples of easier to chew and swallow foods that are more moist and cohesive and soft, right? We're thinking hot cereals, puddings, egg, tuna, or chicken salad with extra mayo and without crunchy bits like celery in it, cottage or ricotta cheese, bean dips or bean soups, etc. Versus foods that may be a little bit more difficult to control in the mouth or to swallow. So dry, crumbly foods like cookies and muffins, bread is a tough one, tough meats, piecey foods like rice and corn, or stringy foods like celery, pineapple, gristle. Again, it's not that a person with ALS needs to avoid all of these foods. It's more so just being aware of what may be more difficult, what may be easier, how to adjust that around your energy levels, and then of course working with your speech language pathologist to figure out what is safest for you and also safest within what are your goals of what you want to continue eating. And then from a beverage or a liquid standpoint, some people with ALS do find naturally thicker beverages. So think milk or milkshakes, fruit nectars, yogurt drinks. They find that slightly thicker beverage a little bit easier to drink than something thinner like water. And if that is the case and thin liquids are quite difficult, you can talk with your speech language pathologist about thickened liquids, whether that's through commercial thickeners, usually in a gel or a powder form, or home thickeners. But I always say is chat with your SLP first. Thicker is not always better when it comes to beverages, but it is an option that can help improve hydration if those thin liquids are causing more issues and thicker liquids are a little bit better. So that then is our transition into hydration. Hydration is important for muscle function. Kind of if we think of our muscles almost like a rubber band, if a rubber band gets really dried out, it's really stiff and it's kind of tough to move. Whereas if it's not dried out, it's stretchy, it's movable. And so kind of the same thing goes for our muscles. When they're dehydrated, they're just a little bit tougher to move. And so we don't want to add that on top of changes in our muscles and our movement with the progression of ALS. So hydration is important to our muscles. It's important to helping thin out oral secretions like phlegm or mucus to make them a little bit easier to clear away. They tend to get thicker when we're dehydrated. It's helpful for constipation management and prevention, as well as our immune function and fatigue levels, just in the sense that fatigue can be worsened when we're dehydrated. Hydration needs vary from individual, depends on your body size, someone who's very short versus someone who's very tall, their hydration needs might vary. But a good rule of thumb, at least as a starting point, is to aim for 8 cups or about 64 ounces of non-caffeinated, non-alcoholic fluid daily. It's not that you can't have caffeine or alcohol within moderation or what is safe for you. It's just that we don't count those into your hydrating beverages for the day. So for your hydration, we want to have the non-caffeinated, non-alcoholic beverages count. And some basic tips, keep that water with you throughout the day. If you're using a powered chair, finding ways to attach it to the chair, using things like longer straws if you're not able to lift the water bottle or container. And that can be something that's done working with an occupational therapist and a speech language pathologist on a water container, straw, whatever setup that works best for you. Just like with eating, setting some external reminders on a phone or a watch, use Post-it notes. Sometimes people will even change their lock screen to a picture of their water bottle as a reminder. Utilizing foods that are high in water content, like juicy fruits, popsicles, soups, ice creams, jellos, or even making like a slushie or a crushed ice by freezing juice or caffeine-free soda, or making a snow cone and using juice. Or I've even done the electrolyte powders that can be sprinkled on top and kind of melts in, almost like a snow cone of sorts that can be eaten with a spoon if that's preferred, as long as the water gets in. And so with that hydration piece, that good hydration can help thin out our secretions, so saliva and mucus and phlegm. Some people do find that dairy products may worsen feelings of thick saliva. And while some people do decide that they want to reduce their intake of dairy products to help with that or try plant-based dairy alternatives, some people find that because dairy products are enjoyable foods and high-calorie protein foods, that they're not interested in doing that, which is understandable. Some people find success just by reducing their dairy intake around the time that their secretions are the thickest. Sometimes that works well. Also, anecdotally, we don't have any good evidence on this, but I hope one day we do. Pineapple or papaya juices are anecdotally helpful to thin out mucus. And that's because the enzymes that are naturally in these juices, so in pineapple juice, it's bromelain, and in papaya juice, it's papain. Those enzymes may help break down some of those proteins that are in our mucus. And so when that mucus has broken down proteins, we're breaking down that mucus a bit. It's thinner, it's easier to clear. Some people also find that the acidity in lemonade or lemon water, or tea with lemon, grape juice, the acidity in those beverages can sometimes be helpful to clear that saliva or thin it out a little bit. So anecdotal, but often helpful from the feedback that I've heard. Another barrier can be eating and self-feeding, and that is where I direct over to an occupational therapist. They are absolute masterminds at suggesting items that can make everyday tasks like eating easier. So a few examples are listed there, but definitely talking with an occupational therapist is a wonderful resource. Another barrier that a person might encounter is constipation. And so there's different factors that can happen that for people living with ALS that, constipation might be more likely. So ALS itself, it affects our skeletal muscles. So it's not affecting the smooth muscles that are in our intestines, in our colon or small intestine. So it's not that those muscles are weakened, but we have muscles around them in our abdomen that are skeletal muscles that we would use to bear down to have a bowel movement. So some people find that makes it more difficult. Additionally, there is some thought maybe there is some sort of kind of slowing of movement of the stool, just neurologically with the nerve connections to our gut. We don't quite know as much, but generally speaking, people do seem to find that bowel movements slow down. But other factors to that can also just be that reduced activity level tends to worsen constipation kind of across the board, potentials of medication side effects, and also decreases in fluid or fiber intake as someone is navigating the, trying to get their adequate nutrition and hydration. And it can be difficult because constipation can then worsen discomfort and decrease appetite further. So it can be a little bit of a cycle. So again, a wordy slide here, but just some tips of things you can troubleshoot to help with constipation. I usually start with fluid first, because while fiber is important, the way that fiber works in the body requires fluid on board. So if you don't have the fluid, the fiber that you take in isn't going to be all that effective. So ensure some adequate fluid intake first. Then talk with your dietitian or doctor about soft ways you can get fiber in your diet or fiber supplements. But it's important to talk about it because sometimes when the stool is moving a little bit slowly and you have a little bit less mobility, too much fiber, we can kind of go overboard and swing someone into constipation. But we don't want to eliminate it either. We do need it. I encourage not skipping breakfast. We have some reflexes in our gut. One's called the gastrocolic reflex. It's the strongest in the morning, and it kind of tells our body to, hey, move things along in those intestines so that we can make room for the rest of the food we eat. And it's strongest in the morning. So if we skip breakfast, we miss out on some of those reflexes that kind of encourage moving things along. Drinking a warm beverage in the morning can have a similar effect. We can also use, not to replace your breakfast though, in addition, we can also use some things that have some extra encouragement of laxation or having a bowel movement. So prune juice, pear juice, or apple juice, they have natural sorbitol in it that pulls some water into the bowels. I would say start slow there. You can always drink more later, but you want to see how it works first. You can also consider things like prunes, 5 or 6 prunes a day in the morning, or 2 kiwi fruit per day. I also put a constipation pudding recipe and a link to a little bit more information about that. Don't do all of these things all at once. The prune juice, the prunes, the kiwi, the constipation pudding. Don't do it all at once. Try things one at a time. Find what works for you and what doesn't. Including movement as safely able, and then let your doctor know if you've tried some things with your diet and you're still constipated. We may need to consider some medications. That's a discussion not with a dietitian, but with a doctor. And it's not a failure or anything wrong if you need some medications to help move things along. So I'm not going to review all of these quick tips, but you can kind of reference back in the recording or take some screenshots while I'm talking now to have just kind of those quick tips of everything we just reviewed summarized. All right, so last kind of jumping into feeding tubes and decision making. So why might a person with ALS consider a feeding tube? For some people, it's to reduce stress from worrying about eating enough to maintain their weight. Some people feel really tied to eating all day long and focusing on, am I getting enough? Is my weight stable? So this can sometimes be helpful. Some people choose to want to conserve their energy for other day tasks because eating's taking a lot of their energy and they'd rather use that energy for other things. Can be helpful to increase calorie intake, maintain weight, nutrition status. It can become an alternative route for nutrition, but also hydration and medications if swallowing becomes too uncomfortable. And when might a person with ALS consider a feeding tube? Some signs that might prompt those discussions with your care team might be getting really tired from eating, being unable to finish a normal meal, or it's just taking too long to do so, or you feel kind of stuck at the table. Eating's not enjoyable, losing significant weight, eating less and losing appetite, worsening trouble swallowing, or you feeling that eating and drinking may no longer be comfortable or safely comfortable for you. Trouble swallowing medications, where you're wanting to make sure you have an access point for your medications. It also may be something that's discussed even in the absence of the above. If lung function is getting weaker, your ALS team may suggest that now is the time to start having discussions about what your goals of care are about a feeding tube placement. And that's because the procedure becomes higher risk as breathing function gets worse. It's usually recommended that the placement of a feeding tube occur before a certain measure of breathing function that we call the forced vital capacity reaches 50% or lower. We usually want it to be higher than 50%. It's not a hard stop. There are definitely situations where a feeding tube can be placed with a forced vital capacity under 50%. But that's usually a rule of thumb that is, kind of something that we go by and something that can also help prompt those conversations of when, we want to discuss those goals of care. But then, I think a lot of it is that a feeding tube can be a scary topic to talk about. And, I think it's important to have the information to make it a little bit less scary. It's still something that's a big decision, a big thing to talk about, but having the information can help you feel more confident in whatever decision it is that you make. So it's important to know what a feeding tube is. And a feeding tube is a tube that's inserted into the stomach to be used for nutrition, hydration, and medications. Sometimes not all three, but that is what it can be used for. It's often referred to as a PEG tube, so that may be a term that you hear a lot. That stands for percutaneous, that means through the skin. Endoscopic, that's the way they do the procedure, and gastrostomy, meaning opening to the stomach because it goes through the stomach. Sometimes they'll call it a rig tube. That means radiologically, so by X-ray, inserted gastrostomy. And sometimes we just call it a G tube, which the G would be gastrostomy. Some people do have a J tube, which goes into their jejunum instead of their stomach, which is as part of the small intestine. This is less common for people with ALS, but it is a type of feeding tube that can be seen. There are feeding tubes that do go down the nose, but those are usually temporary. Those are not ones that we would see in a population for people with ALS. So that's why I'm kind of simplifying and saying that the feeding tube goes into the stomach. So it can be placed usually one of two ways. Endoscopically, that's that PEG tube. That's done by a gastroenterologist or surgeon. The physician puts a tube with a light and a camera, that's called the endoscope, down the esophagus into the stomach. And that endoscope helps the doctor find the right spot to place the tube. And they just make the small incision that they need to put the tube in. Can also be done radiologically, usually done through interventional radiology that uses X-ray, and a small tube gets passed through the nose, air gets passed into the stomach so that the technician, that provider, can see the stomach more visibly on X-ray and know where to place the feeding tube. And then a small bumper or small water-filled balloon holds that tube in place inside the stomach. And so then how would it work once it's in place? A lot of questions I have to deal with, well, how does it heal? And the best analogy I can give, it's not perfect, I know, but the best analogy I can give is think of it a little bit like an ear piercing. You have like 6 to 8 weeks where that kind of hole, it's healing up. And then, it's just kind of present. It's there, and, the skin around it is healed up. So you have some special cleaning that you do to the skin as it's healing up in those 6 to 8 weeks, and your medical team would give you instructions for that. And then after that, you just need to take care of it as part of daily hygiene, but the skin itself should be all healed up around it. And then in terms of using it, you would use tube feeding formula. That's a liquid that provides calories, so from carbs, protein, and fat. Also contains the vitamins and minerals that your body needs, and your medical provider would prescribe that to you and tell you how much to use and when. Most patients give it their nutrition through their feeding tube as a bolus feeding. A bolus means a specific amount of formula that's given several times a day, just like we eat meals and snacks several times a day. And usually, though there's different ways we can do it, most commonly, people will use a syringe that attaches to their feeding tube, and they'll pour the formula into the syringe until they've used up all their formula for that bolus and let it flow by gravity. And this should take about 15 or 20 minutes, especially when first starting. And the way I like to explain that is because if you were to try to eat a whole meal in 5 minutes, you might have a bit of a stomach ache. Same idea if you go really fast with the tube feeding formula. Some people are able to do it, doesn't bother them, but it helps to reduce stomach upset, especially at first, to go a little bit more slowly. Some people also do need a pump to let that formula go into the feeding tube at a slower rate. And then those syringes can be used to give water for hydration, but also around when we give formula or medications to keep the tubing clean and prevent clogs. And some medications can be given through a feeding tube as well. Not all can, so it's important to talk with your pharmacist or doctor about it. But I always say, if you're putting anything other than water into the feeding tube, bookend it with a small flush of water before and after so your tube is clean and doesn't clog. And there was actually a really nice webinar conducted through Neil's on feeding tube management and consideration. So that's linked there, and it's on the Neil's website. So at the end of the day, your goals of care around a feeding tube are completely your own. The information that I provide today and when I'm working with my patients in clinic are not to sway your decision one way or another. The most important thing is that you feel your decisions are fully informed, so that when you make that decision, you find that it's based on full confidence of you knowing pros, cons, ins and outs, and not that the unknown is playing a role in your decision. So as long as you feel that your decisions are fully informed and feel right for you, and your decisions may change over time, but as long as that decision feels right to you, that's all I want. And so how a person may decide to approach a feeding tube can change over time. We have patients who use feeding tubes for all of their nutrition and they don't take anything in by mouth by choice. Some patients use the feeding tube for all of their nutrition and hydration and eat and drink just what they want for pleasure because they enjoy the taste of it. Some people use it for the majority of their nutrition and hydration and eat a little bit. Some people flip-flop that. They use the feeding tube on lower energy days and they mostly eat by mouth. Some people use the feeding tube just to help boost their hydration or certain meds that are tough to swallow, but they eat mostly by mouth. Some people get a feeding tube placed early but don't use it because they don't need it yet. Some people choose not to get one at all. And sometimes this changes over time for different people and kind of go through different aspects there. There's not one right or wrong answer as long as you feel it's the right answer for you. And I did also link a good feeding tube decision-making and information tool for ALS from the Les Turner ALS Association. So just a few quick feeding tube frequently asked questions that I often get. One is, if I have to get a feeding tube, does it mean I didn't try hard enough to eat enough? Absolutely not. Needing a feeding tube is nothing that you did wrong. Will I have a tube going down my nose or throat all the time? Nope, it goes into your stomach. Does a feeding tube fit under your clothing? Yes. We can see here the standard feeding tube, that's the picture on the top, is a few inches of tubing that extends from the body, and it's secured for moving around, usually with medical tape. Some people do via a fixation device that kind of like a belt that kind of holds it in place so it doesn't move around too much, but it does easily go under clothing. Some people choose to have their tube exchanged for a low profile tube. That's the bottom picture that doesn't have those few inches of tubing after they heal from the initial tube placement. Again, when I get the question of, well, why do I have to wait to get the low profile tube? The best answer I can kind of give is it's easier to heal if there are any complications with that longer length of tubing, but think of it as going back to that ear piercing. You're not allowed to change your ear piercing for like 6 to 8 weeks until it's all healed up. Same thing, they can't exchange that feeding tube for the lower profile one till they make sure all is good with that original standard tube. Again, it's not a perfect analogy, but sometimes it's helpful. What do I do if it falls out? Don't panic, but do go to your local emergency department to have the tube replaced unless your team has provided you with other specific instructions. And that's because the opening can close fairly quickly, so it's important to get the tube replaced as soon as you can, but don't panic. Can you still eat when you have a feeding tube? Yes, absolutely. People who have a feeding tube are absolutely still able to eat by mouth, as long as you feel that you're able to swallow safely. But the feeding tube itself does not take away your ability to eat. But it is important to note that whether or not you're eating by mouth when you have a feeding tube placed, good oral hygiene is still important. We are still swallowing saliva, even if someone chooses not to eat anything by mouth. And we should still swallow saliva. But a mouth that is clean is going to have less bad bacteria that goes down. And so if that saliva were to go down the wrong way into the lungs, a clean mouth has fewer bad bacteria that could lead to infections like pneumonia versus a mouth without good oral hygiene. So regardless of if you're choosing to eat by mouth or use fully a feeding tube, good oral hygiene is important. And then lastly, a common question I get is, can I put regular food into my feeding tube instead of formula, or can I make my own feeding tube formula? Some patients do choose to make their own formula with whole food ingredients in a blender. We usually call this blenderized tube feeding. That does require extra time, extra food safety considerations, extra planning to make sure that you're getting 100% of your nutritional needs and aren't clogging the feeding tube. So while it is, in theory, it's a possibility and it's something that can be done, absolutely talk with your dietitian if you're interested in blenderized tube feeding. Don't just start on your own without the support of a registered dietitian. Those are my references, but otherwise, I would love to open it up to questions.
Yes. Hey, thank you so much, Jackie, for that wonderful presentation. We are going to open the webinar up for a brief question and answer. So if you have a question and haven't already submitted it, please feel free to do so using the chat feature or the Q&A feature. And I'm going to do my best to get through the questions we do have. And and I'm just going to go in order of when we received them. So the first one, an audience member was looking for suggestions for unflavored liquid protein to add to soups or similar foods. Is that something that exists? Are you familiar with any brands that offer that or have suggestions for how a person could find that specific type of non-flavored protein liquid?
Yeah. So I'm not aware of unflavored liquid protein. The only one I'm aware of is unflavored but sweet, kind of like how a sugar packet is sweet but unflavored. So that wouldn't go well in a soup probably. But you can take unflavored protein powders and mix it up with a little bit of liquid beforehand and then mix that into a soup. You could also, if it is a cream-based soup, you could use instant milk powder as a way to boost up the protein. There are a couple soup flavored protein powders that are out there on the market as well. So you can look for that. I'm not sure if I'm allowed to say brand names.
Okay, well, and Google's a powerful tool, so I
Yes,
think
it
that's
was
a
a
good
powerful
lead
tool.
that if you're not allowed, then we can just suggest somebody maybe Google that specific type of protein.
Yeah.
A quick one here is caffeine okay, coffee okay, or is that something that should be avoided in the diet for somebody with ALS?
It's a great question. While I always say defer to your doctor, especially if you had any other reasons why you may not be able to do caffeine. Some people with heart conditions avoid caffeine. From just a standpoint of ALS itself, what we usually recommend in our clinic is no more than 2 cups of caffeinated beverages, like 2 cups of coffee a day, just so that you're not getting so much caffeine that it's starting to interfere with the ability to get enough hydrating beverages. So it's not that the caffeine is bad for ALS. It's just that if you're drinking a ton of caffeinated beverages, it's going to be hard to stay hydrated with the decaf ones.
Wonderful. Um, uh, let's say one of the questions we got, let's say somebody has a nutrition related question or they're running into a nutrition challenge outside of clinic, and they don't have maybe a clinic visit for a couple weeks or a month. Any suggestions for how someone might go about that? What they might be the best way to go about that?
Yeah, I think a lot of that would be based on your individual clinic and its workflow. Within our clinic, I would suggest saying to reach out. Some clinics use patient portals, some just provide office phone numbers. So from our end, I'm always fine with reach out before clinic. But if that's not an option based on your clinic workflow, then I would say to just jot it down somewhere, either in paper or phone, so that you remember to ask it when you come to clinic.
Wonderful. And then a comment from the audience that Sam's Club and Costco does have some protein powders that have no flavors. For some of people who are familiar with those stores, that might be an option.
They do, yes.
Um, okay. Excuse me. One of the audience members has seen some ads for a supplement called the Deanna Protocol. Are you familiar with this supplement? Is it beneficial, or is that something you haven't heard of?
Yeah, I've heard of that supplement regimen before. It doesn't have firm evidence base behind it at this time. There is a great kind of breakdown of it on that ALS Untangled website that I referenced. So I would definitely suggest if you Google ALS Untangled Deanna Protocol, you can get some good information there.
Okay, wonderful. Um, for someone who might have questions about recommendations for rate and speed of the feeding tube pump, who would be the best person to speak to about that?
Again, this can vary based on your individual situation. For some people, it may be your infusion company. So that's the people that, give your supplies and formula and all of that. Some people, it may be your dietitian at ALS clinic. But ultimately, it's going to be very individualized based on how exactly your situation is set up with a feeding tube.
Okay. One of the audience members, excuse me, mentioned that they've been having some issues with their feeding tube of formula or even stomach bile coming back through the tube. There doesn't appear to be a blockage. Any recommendations or anything that might be causing that, or who they would be best to speak to?
Yeah, I couldn't answer in your specific situation. I apologize there, but definitely I would encourage you to reach out to whomever it is who is managing that tube, be it your dietitian or your physician, your infusion company, if you haven't already done so.
Okay. Um, how early is it recommended to have a discussion about feeding tubes? Is it worth having this conversation? Is it ever too early to have that conversation? I'll phrase it.
Yeah, it's never too early. And what I mean by that is that it's all up to your comfort level. So some people find that early on, that's not something that they're ready to talk about yet, and that's okay. But if someone, at their first clinic visit wants to discuss what everything might look like throughout the course of things, absolutely, it's a worthwhile discussion to have. It's never too early, but don't feel like you have to have that discussion right off the bat. Generally your ALS team will bring it up if there's a reason they think that it's time to start having those discussions, but absolutely you can initiate them on your own prior to that happening if that's something that you feel comfortable with and you want to get that information. Never too early, I say, to have information.
Okay. One of the audience members mentioned that their loved one has decided not to get a feeding tube and is just curious about ways to prepare for that. If there's suggestions for when that person is no longer able to eat, and I apologize if you're not able to answer that question, but um, certainly
Yeah,
something that I'm sure a lot of people deal with.
it is. It's definitely something that a lot of people deal with. And I think, well, I couldn't comment on the exact situation. I think in general, it's same ideas in the sense of we want to have foods that are soft, we want to have foods that are favorites, we want to have foods that are enjoyable. Um, you know, and having those really open discussions with your loved one of, what is this going to look like? How do you want to approach this, knowing that your goal is to not have a feeding tube? But how do you want to? There are some people that they want to be really aggressive with saying, I'm going to want to be encouraged to eat. I want to try to eat as much as possible. I have some people who prefer, I'm just going to eat as I feel comfortable, but I don't want to push it. And so really having those goals of care discussion, with your loved ones, with the medical team, so that they can also provide appropriate support in the care process as things go on.
Okay. And we have just one more question, and this is on vitamins, and I'm not sure if you're able to answer that, and that's okay if not. But just that they mentioned vitamin C specifically, that it was contraindicated for those with ALS. Are you, are you familiar with that? Is that something you're able to answer if that's correct, or is that something they should maybe talk with the physician about?
I would talk with your physician about it. Generally speaking, we don't recommend it in the sense that there's not proven benefit for it to be beneficial. I have not heard of it being specifically contraindicated in ALS, though. However, if I would love, if there's information out there, I'm always willing to learn. But from, my experience, I would say check with your doctor and kind of get some clarification on that.
Wonderful, wonderful. And I'd say that's probably a good blanket statement for vitamins in general, because I see a couple specific questions about vitamins. And it sounds like just talking with the physician at clinic would be the best way to go about those specific questions. It looks like that is all the questions we have right now. So once again, I would like to thank our wonderful speaker, Jackie Klunk, for the amazing presentation. A couple of quick reminders. You can view a recording of this webinar on our Care Services webinar page. A copy of the slides will also be included with the recording, and these should be available within about a week. I also want to point out on that webpage, you can view all of our past webinars, as well as sign up for the upcoming webinars. We host 2 webinars every month. We also have some very helpful resources and fact sheets on nutrition with ALS on our website, so I encourage our audience to check those resources out on the website. And lastly, a final reminder that you will receive a short survey when this webinar ends. And with that, I just want to thank everyone who was in attendance today, and another thank you to our speaker, Jackie. We hope you have a great rest of your day.